is the status of it?
Discussion is already there behind the scenes, but allow us come on air now and of course delve straight into our tech note. The 2023 Uganda Demographic and Health Survey is something that you ought to look at. Now, policymakers on a daily basis are sifting through thousands of pages of data that has been availed by field clerks who are able to come up with figures and trends that can inform policy and especially the decisions that are taken by the men and women who hold these things. These are the pens that sign off a lot of stuff. So today we are going to be hearing from experts about the Uganda Demographic and Health Survey. What is it? What does it entail? When it's out, who looks at it, and what happens after they have had that look at it? I'm joined by the Assistant Commissioner, Reproductive and Child Health at the Ministry of Health, Dr Richard Mugahi. Many thanks for making it.
Thank you, thank you.
And many thanks to Dr Brenda Kharono. You're a medical doctor and a global health specialist. Welcome.
Thank you for having me here, Chris.
I'll begin with Dr Mugahi. The Uganda Demographic Health Survey, the word in itself is scary to the layman like me. What is it?
Well, thank you so much, and good morning, our viewers. We are happy to be in the studio this morning.
You're most welcome.
Of NTV, and thank you, the management, for allowing us to share what this demographic health survey means to the contemporary Ugandan out there. Of course, as you mentioned, the word demographic sounds so big, and health. Health, really, to simplify this, is whatever we do in the health sector, we monitor and also measure. Because the health sector is an investment. We have inputs, we put things in place, we provide service. It's a service sector.
That's right.
And at the end of every 5 years, we say, how are we progressing? Are we able to measure if we are improving? The other group of people, statisticians will call it indicators. But indicators is really about measuring. Are we making progress? Are we retarding? And if we are not making progress, where do we need to tweak? Where do we need to adjust a little bit so that we get the best possible results we want? And every 5 years, we set our strategies to improvement. We set targets, we set standards, and how we are going to measure that. So the demographic health survey is done by every country, and it's used as a standard for measuring how the country's health system is progressing or improving.
That's right.
So for Uganda, we call it the UDHS because it's Uganda Demographic Health Survey. When you go to Kenya, they will call it KDHS. So every country will have that UDHS at a standard period of around 5 years. And because of COVID, ours came out a little late, 1 year after. So the results were recently released. And it was not surprising because Uganda has made investment in health. The results are showing great improvement. I can't say they are phenomenal because we still have challenges. We still have gaps in there. But compared with other health systems globally, this is one of the health systems that has shown tremendous improvement despite the shocks of COVID-19 and the shock of Ebola that we had to go through, and we think that is commendable. So this is a huge message that we really want to amplify, that these improvements, first of all, they should be able to restore public trust that their system or the system, the investment they are doing is actually delivering. It might not be delivering 100%, but it is alive and responsive.
That's right.
Yeah, and that is primarily why we are here. And the health survey, personally, my area of interest is reproductive health. So it brings out the health indicators that are reproductive, child health based, and they all showed an improvement. You remember a few years ago, we used to talk about women dying, a whole taxi. We are losing a whole taxi of women.
14, was it 19?
14, 16-seater.
Yeah.
But I want to tell the public now on a daily basis that has halved We have halved that because of our interventions. It has come to a half. Tremendous improvement. The number of women delivering in health facilities has gone up. That is what we want to see. We want to achieve 100%, but we now boast of 91%. Women are coming to deliver in health facilities. That's the recent statistics. Very good, because that is the place where they should deliver from. Not from the traditional birth attendants, not from their mothers-in-law, because every pregnancy carries a complication. So children are also coming to for health care when they are sick. They are being brought on time, and that has brought the number of children who are dying because of sicknesses with complications also to come down. We want this to be completely off, because there are still preventable deaths that are happening, but we want to see this improving, and that's the reason why we are here, to say where are the bottlenecks, and we shall be discussing this in the course of the discussion. All right,
you give what is no doubt a very good picture, but that is on the policymakers' perspective. When a survey is conducted, the average Ugandan, or including the media, we are looking out for the pain points. What are those aspects that Ugandans are still grappling with? You spoke of the fact that COVID-19 affected our ability to intervene. No little wonder that the report also, or rather survey results, come out later than they ought to have. And that, of course, speaks of those particular challenges. You will be taking us through those ones very shortly. But allow me come to Dr. Brenda Kharono. Safe motherhood seems to be something of grave concern. Great, not grave. And it is one thing you need to give us an overview of how we are in terms of numbers. I'm seeing a few figures here that indicate that an estimated fertility rates are estimated at 5.2 children per woman in Uganda, and that is a decrease from 5.4 not 2 years ago, but 8 years ago. Wow, those are high fertility rates. What's happening?
So essentially, as regards the Uganda Demographic Health Survey, most of the data we see, we need to use it. And this is what pushes us to safe motherhood. And in the context of Uganda, what is safe motherhood? I would speak on my part as a woman seated here that is directly impacted by the family planning methods, that's directly impacted by the services given. Safe motherhood in itself requires the support of many diverse sectors of the nation, the families, the educators, employers, and healthcare providers. Additionally, exactly as you said, the media, the community groups, and others. So good maternity care investments are all physical, emotional, social, economic, and they affect families in many ways. When one mother dies, that's a whole family that's going to struggle. But when we look at the country in a whole, as the Assistant Commissioner mentioned earlier, we've made some leaps and bounds to where we are, but we're still challenged. For example, when we look at the modern contraceptive rate in the country, 38 from the Uganda Demographic Health Survey results that were put out by UBOS in September, 38% of the marrieds in the country are using modern, that's the prevalence of modern contraceptive use in the country. That's only 38%. That means there's met need and unmet need of family planning going on. And then when we look at the teenage pregnancies, at this time we expect our children to be in school, our children to be engaging in anything else besides sex. That's right. But there's social structure systems we can't control, like in refugee settings as well as rural-urban poverty. Here we're seeing that consistently over the last 3 demographic health surveys, the teenage pregnancy rate between 15 to 19 years has been 24 to 25%. So that means that we're not moving, we're just there. Yet we know so much investment has gone into curbing teenage pregnancies. So what are we missing out? What can we do as the general public? What can the community do to support the healthcare workers? And then when we look at the maternal mortality rate, the demographic health survey is that snapshot in time that brings data over a time period. That means that you can't use that to compare with what we're going to produce at the end of the month, which is annual. This one's very specific, using specific methods of measurement. So when we look at the maternal mortality rate, we have the Commissioner mentioned, we have halved the taxi. We are now in an omnibus. An oxymoron, but the number is still there, but we are less than where we are from half.
Right. Yeah.
That is such tremendous progress in just a period of 7 years.
Positive
More needs to be done.
Yeah.
Actually, a positive trajectory in reducing maternal mortality and achieving Sustainable Development Goal 3. And in many ways, the NEMO, we know that whenever we save a mother, chances of saving the child are high because we provide integrated care. So mainly, we have been concentrating on one, addressing the teenage pregnancies, and also such platforms helping us address what we call the first delay, the delay to make a decision to come for care, right? So yes, we could have some challenges where we are working on them, but what can the community do on the other side to increase the modern contraceptive prevalence rate, to reduce the maternal mortality rate more, to increase male involvement in the continuum of safe motherhood, right from when the woman gets pregnant to when she delivers, and to also reduce the rate of the babies dying immediately after delivery. While it has gone down, it's just by about 5. And so we would hope that if we engage the community, we engage media, we're able to help them reduce the time they take to make the decisions to come to the healthcare system for support.
Okay, that's interesting and reassuring in equal measure. There's a lot that is going on to ensure that our mothers are safe, but most importantly, to ensure that mortality rate is brought down. It's a very scary trend. People don't pay attention to it, but when you understand that you're losing mothers in ways that are avoidable, then that's when the reality sinks in. But let me go back to the Assistant Commissioner. The highs and lows of this particular survey are pretty much good. Safe motherhood, reproductive health is pretty much something that we now know is in safe hands, and where we're going is where experts want us to go.
Yep.
But there are other aspects that the survey or research, I don't want to say researchers, stuff that was captured that we need to know about. HIV/AIDS, malaria is there. There's a lot of other interventions in terms of diseases that happen as a result of the changing patterns in climate change. Just bring us up to speed with the highs and the lows, so to speak, of the survey.
Thank you once again, and as I earlier mentioned, that in this survey, like a dashboard really, when we receive this report, we interrogate it more. We dig deep into the realities of the report. We notice that there is regional variation. When we say 5.2, when we say 1.8, or whatever figure comes out, it's not standard across the country. It was well noted that some areas of Uganda, let me choose an example of West Nile, had poor health indicators across all the parameters. The child health indicators were not good, the newborn indicators were not good, the maternal health indicators were not good, and there was that consistent variation across other regions. Karamoja, an area was Karamoja had a higher fertility than the others, but the maternal mortality rate was low.
Karamoja, higher fertility.
Very surprising. That's the beauty of research. Actually, Karamoja is leading in fertility. So you are now going to get interested more.
All right.
So Kampala had the lowest fertility.
I'm not surprised.
3, you no longer want to give babies because the economy is tough. You're making money. So that's the beauty of this study. It gives out, when we receive it, when we receive the report, we interrogate it. We want the public also to interrogate it. We want the media to interrogate it and say, why is this so? And we are also seeing that areas like Bushenyi, that are traditionally food baskets of Uganda, have malnutrition. So the food they are producing, they are selling all of it. It's the economy, it's the market economy. Probably they are selling all the food and they are leaving nothing at home, and there is malnutrition. And for me, as a reproductive health expert, this affects me. Any pregnant woman who is malnourished, I have trouble. the child will malnourish. She has a danger of getting complications,
That's
having
right.
no blood, and you know, all those complications compound the outcomes of reproductive health. So outside that, we see stunting is reducing, but we are having some areas. So that regional variation is something that we are going to interrogate further and come up with targeted interventions after thorough interrogation. So this is our work. So, but we don't do it alone. We have a series of stakeholders. We have stakeholders at service delivery points. We have stakeholders at different MDAs, like food production is not directly a mandate of health, it's a mandate of agriculture.
Yeah.
So if people are malnourished, which we see on the health dashboard, then we should be able to inform agriculture. Your people in Ushenyi are not eating well. That's what we are seeing. Are they producing enough? Because production is a function of nutrition.
They could be producing a single...
So, yes, that's what the dashboard is telling us.
Yeah.
So when we interrogate this further, we also think that we have a unique opportunity to see who is being left behind. The 189 women who are dying, who is actually dying? Because we can be able to produce and say, is it the young people? Is it the elderly? And what is killing them? So we do this on a routine basis. We've been doing that on a yearly basis because we audit all the maternal death in this country. And we have a record who died and where, at what age, what killed them. We are able to use this data and synthesize it and say, okay, it's the poor who are dying. Why are they dying? It's the rich who are dying. Is it that our information packages are not reaching them? And why are they dying? And that's why Brenda came in with delay. The biggest cause of maternal death and death here is delay. People delay to present themselves to appropriate care. You see ambulances rushing. People have delayed somewhere. They self-manage. They treat themselves. They go to traditional birth attendants. And we are saying there is a unique opportunity. The healthcare is making progress, is improving. Still have gaps, but we are improving. And we can, if you present yourself early, then we are able to survive, to save you. Because unlike a car that goes to the garage, for us in health, every minute you lose, you're losing life.
That's right.
Very critical. And we keep encouraging people and we keep emphasizing this. We want to work through stakeholders like you to say every minute you lose, if you're not feeling fine, please reach out to the healthcare system.
Okay.
Either the public or the private, whichever healthcare system, because your investment, the responsibility to move from your home to healthcare is your responsibility.
That's your responsibility.
And that's why we are saying delay number one is our biggest problem. That family, the mother, the parent, the man, making a decision that now we need to move for healthcare. There are a number of barriers. Some of them are economic. Some of them
I was just about to ask that perhaps the reasons other people delay to come forth and seek some of these services could be structural, could be economic, and cultural sometimes.
Absolutely.
So what are the approaches that are being used to ensure that each is dealt with and how it affects the other is well understood, especially by the women who are considered to be delaying?
Brenda will add, but let me give it a shot. The approach for this level is the reason why we are here.
That is right. And
I told Brenda that our biggest message is not the demographic health survey. Ugandans will not listen to these figures.
It's a humongous document.
Yeah. We are here. That's a dashboard. Yeah. It's a dashboard of a car. But we are here to tell them that whereas the supply side, we health workers. From the supply side, we have obligations to offer care. The individual, the beneficiary, also has an obligation to seek care and timely care, timely seeking of care. Now, the approach is going to be multi-sectoral. The approach is multi-sectoral. At community level, we have so many gatekeepers. We have leaders. We have cultural leaders. We have religious leaders. We have civil leaders. We have family heads.
That's right.
Our message here is don't keep people who need care, health care, at home. Don't delay them at home. So that's the key message. Tomorrow, as a matter of fact, as part of the commemoration of the Safe Motherhood Month of October, we are meeting religious leaders in the entire country, top religious leaders, in a dialogue about safe motherhood. We are discussing these results. We are telling them what their role is supposed to be. We are going to meet cultural leaders next. We are going to meet the media in a special platform. We are going to meet young people and the CSOs that are working with young people. So this is an engagement that the health sector has worked out to make sure that the multi-sectoral platform comes out. But also government ministries, we work with Ministry of Gender, Ministry of Education, so that we make it complete. Maybe Brenda can add on the approach.
Yeah. So essentially, as we talked about the first delay, many times we only think of lack of partner support or lack of money. But as you mentioned, there are different components of the system, the individual level, the societal level, the cultural level, the political level, and of course, lastly, the direct health system level that forces someone to delay to come to hospital. And those are some of the points that we hope to address when we are advocating for safe motherhood. And part of the household level, of course, talks about the other sectors, you know, inadequate education or inadequate advocacy messages to the community on safe motherhood or where they can get services. Low exposure to healthcare messages. Not everyone maybe can afford airtime or receive that SMS that says, you know, there's a medical camp or antenatal care at this facility. Then when you look at household level, is lack of birth preparedness plans. But what does that mean? Where is the partner? Lack of partner involvement. Many times, research has found that many mothers report they would benefit from being escorted by their partners or their husbands to the facilities. And because it's one of those silo unspoken conversations in communities.
Speaking for women.
Well, the men don't want to come. The men don't want to escort us to the level. So I will ask Chris to tell us whether he escorts his partner for antenatal care and whether he knows the birth plan. Many of the partners are not aware how the women will deliver, where they will deliver, and that in itself is a worry. And when you look at the teenage pregnancy cases, it's even worse. You became pregnant as a teenager, so you are in hiding. You don't have a partner to show he's gone back to school.
That's right.
That means you are scared of going to the facility to sit with older women to get the same care you're entitled to. Who are going to say,
yes,
you didn't go to school. You were busy having sex. That's already judgmental. I will not come.
That's right.
Right? But that is the narrative for so many teenagers and where we lose very many of them along the continuum of care. But on the other front is what can we do to address this? What can the system do? Involving schools and education, just even sharing some of those advocacy messages about available support for teenagers, available support for in hospitals and special corners for adolescents, but also encouraging parents and the society itself to support these teenagers when they come with these problems. Because despite the conversations, there's still stigma around teenage pregnancies. By the time they come to hospital, we report a maternal death in the 15 to 19 years age category. For the male involvement, when you look at it, I'm seated between men, and they should be advocating for rights, but they are also the conversations that maybe they don't know about. How else can we get them in? How can we incentivize them to come to the facilities with their partners and help them make birth plans so that, you know, if we're planning for cesarean section, this is how much. If we're planning, you know, that helps us improve the chances of having better outcome. Research shows that kind of planning and antenatal care visits will be able to predict a better outcome for that mother, as well as getting message-specific information at each stage of pregnancy.
All right. If I've been put on the spot, and usually when a challenge is put onto you, it's important that you take it on.
Oh yeah, sure.
As being a man, I think facilities and hospitals ought to create spaces that are conducive for men. If you come into a labor ward with your wife, you've escorted her, and there's all this, and then you meet this plethora of patients, and you're struggling. Your wife has nowhere to sit. That's an average hospital across, for example, away from the metropolitan area. Your wife, the one you've come with, the pregnant woman, has nowhere to sit. There's another woman struggling on the floor. Now, the last thing a man wants is the fact that he has chosen not to go for that 1 million deal and come to the hospital, and all of a sudden there is a lot of stress around there. And then the questions are coming from, oh, you know, this, the other. Next time, he won't. He will solicit the services of either the sister or any other person, please, can you go with her and stuff like that? Because he knows what is there is stressful. Maybe the spaces must be improved. I don't know whether that is feedback enough.
That's wonderful
That's
feedback.
Good feedback, self-motherhood. Thank you for starting.
All right, time is not our best ally. I'll allow you to talk about the fact that this particular survey is going to be this, and self-motherhood will be the subject of discussion at an upcoming conference.
That is true. So thank you very much, Chris. Thank you very much, Assistant Commissioner. So the preamble for this conversation leads us to the National Safe Motherhood Conference that will be taking place from 22nd of October to 25th of October, 2024. You are all invited virtually and physically. Please reach out to any member of the Ministry of Health or the other support partners and stakeholders who are participating in the organization of this conference, including the USAID MCHN activity, WHO, UNFPA, everyone involved in the reproductive maternal-child health continuum, as well as nutrition, including groups such as, NIPIN, World Food Program, and other agencies. You are all welcome. Can we improve the lives of all babies? Whichever mother.
Thank you very much, Dr. Brenda Kharono, Global Health Specialist, and Dr. Richard Mugahi, Assistant Commissioner, Reproductive and Child Health at the Ministry of Health. We are emboldened by your perspective and, of course, sharing this information as it ought to be. That will do it for Take Note discussion, the Uganda Demographic Health Survey. There's a lot to chew on, and of course later I'm hoping to go deep into that document so that I can be enlightened on some of the things that I ought to be enlightened about as a man.